welcome everyone to this LymphaTouch webinar series. And today we are very happy to have Tuulia Luomala here today to speak us about the interesting world of fascia. Tuulia, welcome. The stage is yours, and please you can start your presentation and introduce yourself as well.
Thanks. I will stop your screen sharing and share mine. And when I'm here, I will introduce myself then. Okay, so welcome everybody, and good morning, good day, and good evening for everybody. I am a physiotherapist. I have been working as a physio more than 20 years. I treat animals, I treat humans, so I do 50-50 both. And then I do a lot of lecturing around the world by Zoom and also on site. Of course, last 2 years has been more online webinars, but next week we'll be in Poland teaching animal fascial manipulation. So now it's again time to travel a little bit. And now in this webinar, we are looking the fascia. We are expanding the perspective and looking how the layers are. We are talking about the microscopic view and a little bit about the microscopic view also. But here you can see the layers of an arm in this image. The image is from Plastination Project 2018. And this was done in Germany, in Guben. And now if you want to ask something, you can put it in a chat and we can look the questions in the end. So I will go through the presentation and then you are free to ask what is in your mind. So when we look this picture in the beginning, on the left side, you can see skin. Then when the skin is taking off, there will be superficial fascia and fat. So adipose tissue, and there will be layer of fascia in between that one. I will show you also cross-section of that image, so you will see that one also. The more clear, the white tissue here is deep fascia. And then when we go even deeper, we are seeing the epimysium of the muscles. So this is the system we are looking, and we are going more into details and check what is there. And of course, we are looking the fascia itself. Then we are looking a little bit the idea how to treat fascia. Then scar tissue from the fascial point of view. And in the end, I will give you some treatment examples how to release the scar tissue in different areas. We are looking the abdominal scars, we are looking the facial scar, and then one scar from the shin. And this image on the right, you will see later on, it is from the thorax. You can see the border of the diaphragm, you can see the cross-section of the costes, and then you can see the abdominal muscles and how they are connected to each other. I will talk about this image later because it's one of my favorites for sure. So in the beginning, of course, we need something to understand what is fascia, because if there is a lot of people who are not so familiar with the fascia yet, I will introduce a little bit the definitions and the ideas behind the fascia itself. At the moment, there has been 4 congress of really fascia-specific congresses, and the 5th will be next year. And it will be, was it in Montreal? I think it's in my slide, so we will look at it later on. And well, definition, an interrupted 3-dimensional web of tissue that is extending from head to toe, from front to back, and from interior to exterior. That is a good idea to understand what is fascia. And it's everywhere. It's 3-dimensional web. and it's connecting everything. So it's basics, and you can understand by looking that sentence that, okay, it's really covering the whole body in many different ways. And when you look the image on the right side, and this is Robert's slide, image 2012. And I think this one is highlighting the idea that we can have very dense composition of the fascia. Then we can have very loose composition also. And then how the collagen fibers are orientated. They can be very regular or they can be very irregular. And best example of the very regular and very dense composition is Achilles tendon, for example. And then loose connective tissue, superficial fascia, for example, they are irregular and they are very loose. So there is a lot of elastin inside, and the tissue can be very flexible and very adaptable. And when you have very regular and very dense composition, then there is only a couple of % of elasticity in that area. So the tolerance is very different according to the different places in our body. Yes, the next Congress will be 2022 at Montreal. So if you get very enthusiastic about the fascia, you could join us there. 2018, we got update of fascial nomenclature, and this one is also very good because, again, here the same idea about the three-dimensional continuum of the soft collagen containing loose and dense connective tissue. It is holding the whole body, permeating different places. It is incorporating elements such as adipose tissue, adventitia, neurovascular sheets, aponeurosis. Then we are having the deep and superficial fascia, epineurium, joint capsules, ligaments, membranes, meninges, and myofascial expansions. This is also very, very important when we are looking and when we are treating with LymphaTouch. The myofascial expansions are the areas where we want to have also some of our treatments. I will tell you that later when we are looking the examples then. And then the periosteum is also included, retinacular areas, and retinacular areas is also very important when we are thinking rehabilitation at the joint or the ankle sprain, for example. Then septas, tendons, those are coming very important when we are talking, for example, hamstring injuries or other tendon injuries where we are having also myo and fascia both connected. Visceral fascia and all the intramuscular and intermuscular connective tissue is also included in this definition. So endoperi and epimysium all are connected. And the fascial system, it's surrounding everything. It is between everything. It is interpenetrating all organs, muscles, and bones. So these few sentences are really giving the idea how fascia is covering things. It is connecting things. It is also separating things. So we are having everything really connected, and at the same time, fascia is providing this kind of environment where the other body parts are operating as an integrated manner. So we are really talking about the that kind of structure which is holding things together and connecting body parts together. And when we are looking at this image, we can think that human inside, beneath the skin, we are having the skeleton, we are having the bony parts, we are having the myo parts, so the muscles, how they are connected. Then we are having vascular system, lymphatic system, nervous system. We are having this kind of adipose layer holding every place of our body, and then fascial system. And now when we are looking all of these connections and thinking the treatment and thinking also how the LymphaTouch is affecting different kind of places, we can look in some places we are more focusing towards the lymphatic system and then also increasing the blood flow, or we are having effects on the very superficial parts to the adipose tissue and the adipose body, and also in many parts we are having we are focusing towards the neural system. We have this kind of sheets where the nerves are penetrating different layers, and in those places we are having also acupuncture points. So we can go and have the treatment around those points and have a big relaxation through all the nervous system and also through the myofascial body. And when we are looking this kind of layer compartment, we are first looking skin, and then we are having superficial fascia where we have the adipose tissue also connected. In this image, you can see how they are organized. And then we are having layers of the deep fascia, and there is loose connective tissue between everything. And we are having the muscle, the tissue, myotissue itself. And then we are talking a little bit with the extracellular matrix and also a little bit about the cells. Fibroblasts, fasciocytes are the ones I want to mention to you in this webinar. When we are looking at the connective tissue, it is really formed with many parts. So we are looking cells, fibers, and ground substance. And when we are looking at the cells, we are talking about the fibroblasts, chondroblasts, osteoblasts, adipocytes, all of those which are there, what we cannot see with our bare eye, but we can look at in the microscope. And for a while, I will tell you something about the fibroblast. Here is an example of the adipocyte. So there will be also the fat reservoir will be inside, and the cell membrane is holding the whole cell itself, and there will be also nucleus and mitochondria in that one. And then when we are looking the fibers, we are talking about the collagen, elastin, and reticular fibers. And in this image, you can see how the elastin fibers and fibroblast and collagen fibers are forming this kind of matrix. So they are connected to each other, and they are talking to each other and forming this kind of mesh. In some kind of places, it is containing more collagen, and in some kind of places, there is more elastin. And that is giving the elasticity to our body. And then when looking the ground substance, we are having water, glycosaminoglycans, and ions in that one. And here is an example of the glycosaminoglycan, which is hyaluronan, which is very important when we are looking the fascia and the layers of the fascia, because the loose connective tissue is holding a lot of hyaluronan, and it is giving this kind of liquid surface for that one. And in this glycosaminoglycan, we are having the end, we are having the proteoglycans, glycosaminoglycans, and then we are having the link proteins, which is forming the hyaluronan and the chain of hyaluronan. And 3 days will be the turnover time of the hyaluronan. So it is meaning that we need to move our body, and we need to go through every joint, range of motion, every movement aspect we have in our body. We should be moving through our body in every 3rd day to have very well working hyaluronan. Of course, our system is working nicely when we are walking, when we are pushing, lifting, turning, rotating our body every day. But anyway, like the minimum amount of movement is needed every 3rd day to get this kind of lubrication of the system going on. And ground substance, we are talking about the extracellular matrix, which is holding everything around the cells. And this is also the molecular storage. It is catching and releasing biologically active molecules, and it is regulating tissue and organ functions, growth and regeneration. So very important thing, what is from the hormonal and also from the biochemical point of view. And of course, we are holding a lot of liquid inside. So in that way, the ground substance, extracellular matrix, all of those are very important when we are thinking the movement, treatment, how to treat them, and how to affect the body itself. Here, fibroblasts, so they are really connected to each other and they are forming a network. And these ones are producing and maintaining the production of the collagen and elastin. So when we are having the tension and the compression, the tissue is stimulating the fibroblasts. So we are having the orientation of the collagen fibers in the in different directions, and also many hormonal receptors are participating the modulation of the fibrosis and inflammation. If you want to check more about these ones, you can check these articles here. So Liao 2014, Catherine Fede 2016, she has done a couple of those, and Carla Stecco has been part of these articles also, where they have been looking hormones and hormonal receptors, how they are in a human fascia, and how the endocannabinoid system and the receptors are working in the human body. So these two are made in the University of Padua. And when we are looking the fascia sites, they are specialized fibroblasts, and they are specialized for the production of the hyaluronan. And now when we are having this kind of shear forces, these shear forces, so the tension and compression together, they are activating fasciocytes to lubricate the tissue. And about 30% of all fibroblasts are fasciocytes in healthy body. And now when you are looking this kind of image here, you are seeing loose connective tissue. And there in the loose connective tissue, we are having this kind of round shaped fasciocytes. You can see it here also in the upper image, these like eyeballs here, they are fasciocytes. And then we are having also fibroblasts. And fibroblasts are this kind of like these ones here, which are not round shaped. So these are fasciocytes, and fibroblasts are all over in the loose connective tissue also. And dense connective tissue will be the layer which is there holding the system, and between everywhere we are having the loose connective tissue. I'm showing you also a couple of images how the loose connective tissue is and how the dense connective tissue is, so you can really understand how the system is working. And now when we are thinking the negative pressure, we are having the suction, and at that one, when we are moving the nozzle, that is creating this kind of shear force, and by that we can really activate the fasciocytes, and we can also activate the fibroblasts. And the myofibroblasts are very important when we are having the wound and the scar, because at that point when we are having problems, fibroblasts are specializing to myofibroblasts, and they are activating and they are contracting and they are closing the area of the wound. So those ones are very important in that time. And when the wound is closed and the scar is there, then the myofibroblasts should go away, and then we are having again the normal production of the fibroblasts. And now we are going more in the macroscopic level. So we are roughly dividing the connective tissue to the loose connective tissue and dense connective tissue. And loose connective tissue you can see here on the lower picture. So it is very moist, it is glittering, it is very irregular, and it is very elastic. So like you remember in the beginning, when we have very irregular, very elastic thing, we are having loose connective tissue. And when we are having very dense connective tissue, we are having orientation of the collagen fibers. You can see that one, and it is very white and like a sheet of a fascia. So it's very clear when you have the dense connective tissue and how it is orientated. Deep fascia is in many places in 3 layers, so there will be 3 sublayers on those ones, and we are looking also that one. And it's very important that these 3 sublayers can move respect to each other. So we need movement between the layers. So Ida Rolf was already 1980s thinking that, okay, that what we need to get this kind of movement between the layers. And nowadays we know that for sure we are having problems if the layers are not moving. I will talk about that one a little bit later. And when we are looking at the dense connective tissue and how it is divided, we are talking regular, irregular, and elastic. And here are a couple of examples. So the elastic one we can find in aorta. And when we are looking the irregular dense connective tissue, we are looking the pericardium, periosteum, joint and organ capsules, and for example, skin. So hypodermis will be one example of that one. And maybe the most known and most typical one when we are saying that, okay, dense connective tissue, we are talking about the aponeurosis, we are talking about the tendons, ligaments, retinacular areas, and epimysium. And here is an example of the superficial fascia. To get you an idea, where is this? This one is an glenohumeral joint. So we are talking about the trapezius would be here, deltoid muscle would be under here. Here you can see a corner of the breast, the corner of the breast, and then we are having the humerus will be going in that direction. So you can see that when we are looking under the skin, we are having this, like this very small black lines here are vessels. So there is a lot of vessels and also a lot of small nerves in the superficial fascia. And when we are looking and taking part of this layer and looking at the cross section of that one, you can see that there is this kind of lobules. So this here would be the superficial fascia itself. And then we are having adipose tissue in those bulbs or corners or lobules, you can call it lobules. And this is the thing, if you are thinking that, okay, human is covered with this kind of superficial fascia and layer of fat. And now when we are doing the negative pressure on these ones, we are really doing also things for the superficial fascia. And if there is edema, if there is a lot of tension under the superficial fascia, then also this one will be very painful because we are having also receptors in this area. I'm talking about the receptors also later, what kind of receptors we can find. We are finding receptors from the skin. We can find receptors in the superficial fascia and also in the deep fascia. And there in the loose connective tissue, we are having a lot of receptors, pre-nerve endings. So they are sensing the tension, the pressure, the rotations of the body, torque, and also this kind of shear forces, what the body is facing. And also these are coming from the fascial plastination project. And now in the Montreal Congress, there will be first time ever this kind of sculpture of fascia, which is made of human body. So it's von Hagen's and the Body World exhibition. They have been working hardly together with the Fascia Research Society and creating Freya, which is now showing first time the fascia and other parts are removed. So that will be very, very interesting happening. Okay, then we are looking the deep fascia of the back. So now you can see roughly here we are going under the skin and we are looking the superficial layer, middle layer, and the deep layer of the deep fascia. So it is really holding this kind of 3 compositions. So and the muscles are divided like in the pockets. So we have something, we have pocket for the, or envelope. We are having envelope for the erector spinae. We are having envelope for the rhomboids, for the trapezius. So, and also for the latissimus dorsi, we are having envelope for the glutes. So everything is covered with this fascial layer. So you can see from these images when the skin is turned off that, okay, we will see that yellow mat, which is superficial lat fascia. And when you are looking, you can see on this image that it is really flexible looking tissue. And when we are going under this one, we are seeing thoracolumbar fascia. So to give you some points where we are, here will be sacrum, and the spine will be going towards the head like this. Then we are having latissimus dorsi like this, and then we are having the glute max like this. It's like a feather or like a leaf when you're looking the thoracolumbar fascia itself. And maybe on the next image, it's maybe more clear with the crisscross orientation. And now when you really see the crisscross orientation, L5 would be more or less in this, like where you have this star formation coming together on that one. So now when you see this one, you can really understand the processus spinosus will be here in the midline, and there the cross section will be going around and crossing over the processus spinosus. And when we are having this kind of crisscross, you know that there will be force going from left side to the right side and vice versa. And now when we are thinking the movements and also the treatments, we should be going really three-dimensional way. So we should be moving it this way, this way, this way, this way. So every corner should be connected when we are doing the treatments. If we are using our fingers or if we are using the negative pressure, we should be thinking how is the anatomy inside. What there is, if I take the skin off, how it is looking in this area, where we are having this kind of anchor points, like this you could call this kind of anchorage point where you have a lot of tension coming into that area. And then you can see on top of the sacrum, there is very tight sheet where we are having the multifidi muscles connected on that one. And the epimysial fascia of the glute max will be here, and the aponeurotic fascia will be more, it's more wide and more dense if you are looking in that way. And then when we are looking the leg, we can see the same when the skin is taken off. We are scraping the area of the superficial fascia off, and when we are zooming in, we can see how the orientation of the collagen fibers are. So we are having vertical orientation and horizontal orientation. And again, this is very important when doing the treatment. We need something in the horizontal plane, we need something in the vertical plane, and also in this, if I take back here, we can think that the vastus lateralis groove of vastus lateralis will be here, and the hamstrings are connected into the same area. So we are having this kind of septa, which is dividing the area where the leg is moving forward and where the leg is moving backward. And we are having this kind of edges or crossroads or areas where we have a lot of tension. For example, in the head of the fibula, for example, we are having tensional area where we can have a lot of tightness, which can limit the movement of the fibula or even the movement of tibia. And this kind of orientation is very functional, because when we are moving in one movement direction, some layers are moving, and when we are rotating or doing something else, we are moving sideways, different layers are adapting the movement and moving different way. And in that way, we can really think that we need movement in multiple directions. And also when we are doing the treatment, we need to take care that we are moving in different kind of angles and in different kind of directions, not only in vertical way and not only doing the gliding movements like you have been always doing, but you have to think also in which direction the limitation is coming from the tissue and how it should move and in what kind of cross section we are in that area. And now when we are looking the loose connective tissue, it's between the dense connective tissue layers. And I think this is really one of my favorite tissue. Here you can see this is from the horse body. And we have been lifting the scapula and we are looking under the scapula. So you can see how it's like very liquid and very moist and going in every direction you can image. And areolar tissue is another term you can be seeing what is said about the loose connective tissue. So both are used in articles, and it's really everywhere. It's providing flexible layer between the dense connective tissue layers. And this is the thing which is allowing the movement. So when you are thinking that, okay, this is my arm, it's not moving well, it is restricting a little bit, you can do a little bit rotations, you can breathe for a while, you can do rotations, and it's instantly moving more. When you are moving the tissue and when you are just doing the rotational movements, it is allowing the structures to move more, and then it's lubricating the loose connective tissue. So those kind of reactions we can have immediately are because of the nervous system and because of the loose connective tissue is getting more moist. If you are thinking the ketchup, for example, and you have only a little bit ketchup or end of the ketchup in the bottle, you need to take it around and shake it a little bit or tap it a little bit to get the ketchup out of the bottle. So that is a good example. When we don't move the body, when we avoid something, if we have pain or we are having after sprains or injuries, if we are having the avoidance of the movement, then we are having the end of the ketchup in the bottle, and we need shaking, we need a little bit treatment. The lymphatage will be very good in those kind of cases to get the movement and get the lubrication for the tissue. We could get the fasciicides working, we could improve the working of the fibroblasts, and in that way also affect the extracellular matrix and get the movement going on. And the loose connective tissue, like said, it is very rich with hyaluronan, and it is containing fibroblasts, collagen, and elastic fibers. And also very important thing that it is also reacting to the temperature and pH. So if you drink too little, or if you eat that kind of thing which is not good for you, your pH will be altered, and then your body feels immediately stiffer. And of course, here in Finland, we are using sauna to getting our temperature more high. So in that way, you could feel instantly that, okay, I'm so loose and I'm relaxed after the sauna, because the temperature is also making our body more relaxed and more elastic. This loose connective tissue is filling spaces, it's holding, it's cushioning things, and it is also very important when we are talking about the protections of the blood vessels and also organs. So we need this one, and this would be like very crucial for our body to work the way it is working. So no wonder I'm really fond of this tissue. And here you can see our microscopic image of the loose connective tissue. And there are a couple of ideas what the researchers have been saying about this one. Myers 2010 has been talking about the metabolic functions and the stuffing material. Iderov already quite long ago was talking about the extracellular matrix and the consistency of that one and how it is gluing layers together. And Stecco family has been talking about the hyaluronan and its meaning in the fascial system. Robert Tribe is talking more about the mechanoreceptors and how the central nervous system is reacting and how we are having palpable tissue changes. We are looking also those ones in a while. And fluid dynamics, that is also very important if we are looking the loose connective tissue, because it is holding 15 liters of water, and all of this water which is going inside on us, it is affecting the cells and tissue repairing and also the healing process. So and when we are having scars and injuries, the whole body is trying to balance the thing. And if it's not able to balance something, we are having compensational patterns. We are having the compensational patterns anyway, but some are better than the others. And that's the thing. Sometimes we can have pain because of the body is compensating things, and sometimes we are doing just fine and having no problems at all. Yeah, you can see ultrasound image. We are having here the layers, and you can see more white, more connective tissue. So more black there will be in the muscle area where we have the myo. And when we are zooming in, we can see that between the membranous layer, we are having loose connective tissue. And in this image, you can really see when we have the zoomed in image that there is 3 layers, and between there should be movement also. And when looking it's not only the layers, it's also the rings or the compartments. Everything is connected when you are looking from the back to front, from the head to toe. Here, as an example, we are having a cross section of the human thigh. Here, for example, this kind of like a ghost between here. We are having here vessels, and we are having also sciatic nerve. And then we are having connective tissue, which is connecting everything to the surface, so to the skin. And also you are seeing here that we are having this kind of, like in orange, if you cut the orange in half, you can see also that there is this kind of pieces where it's like orange is having also fascia inside, and also the fruit meat there is like ours also. So we are very like oranges or other things in nature. Cross section of the lumbars here in humans is showing us that when we are having rectus abdominis here, the other abdominals, transverses and external and internal obliques, they are holding the system from the sides. And then we are going to the back and having the erector spinae system there connected to the quadratus and also to the area of the psoas. And about this area, there has been also studies. I will show one in a while. This one is also from the horse leg, but one of my favorites also, because from this image, you can see that how we can have connections from the skin and superficial fascia, even to the area of the periosteum. So when we are having tension somewhere, it can affect even to the periosteum. So in that way, when we are doing, for example, lymphatics, the negative pressure here, we can have connections also in the level of the periosteum, and we can move the things in surface, but have very deep effect. And also, of course, the vibrational things are having the effect to the lower parts of the body. So in that way, it's very important. And here with this one, you can see when I'm rotating the bone, you can see how much the movement is going from the lateral side to the medial side. So everything is moving when I'm rotating the bone itself. And here in the middle, you can see the vessels and the nerves. So every part, this is a little bit frost is still, so it is not moving so much, but here you can see where it is not so frosty. You can see how much movement there will be when the bone is moving. So when the movement is coming, there will be a lot of movement in there. And this is the image I was saying that is also very, very dear to me, because if you look this one, you could think that very often you are looking, if you are looking like this, you would expect to see the vertebrae. But when you are looking this one, you notice that in fact, now you are looking from the dorsal side in front. So we are having the abdominals here, and we are having the diaphragm here, an area of the heart here. So we are having and looking now how the muscles and the myofascial tissue is giving a place for the pericardium and the heart itself. And then we are looking this zoomed area here, where you are seeing that the diaphragm, costes, and the abdominal muscles are really attaching together here. And from these points, we can affect inside of the body. So we can really have connections in the surface. So there we can put the negative pressure and affect even to the area of the diaphragm in the deeper parts of the body. And here you can see also pelvic floor from this area. So it's like a container. It is holding everything together. And in a while, we are looking also the area of the hip joints, how they are there. And also, if you are thinking the container, we are having the floor as a pelvic floor, and then the roof will be the diaphragm itself. And then when looking around, Andrew Vlaming has been doing studies about how the erector spinae as a compartment is working. The area of the lateral raphe will be very important from the treatment point of view, and everything here is connected to the abdominals, and they are working together and working in a harmonious way. So that is also very important when we are looking the treatment and thinking what to do for the body. This is also a little bit, I would say, rare image. It's coming from the fascial plastination project, and now we have a cross-cut in a horizontal way. So you are seeing bladder, you are seeing the muscles of the pelvic floor, then you are seeing the area where the hip joints are coming, and then the area how the muscles of the muscles which are coming from the rectus femoris, vastus lateralis, vastus medialis, how they are connected there. And then you are seeing the glute medius here. So gluteus medius on the both sides, you can see how it is connected there. And then we are seeing abdominals here. And when we are looking the rectus femoris itself, it's very aponeurotic one. And you can see, like I was showing to you in the thoracolumbar fascia area, there is this crisscross also on top of the rectus femoris. In the anatomy images, quite often you think that, okay, the muscle is there and I would go there. But in fact, again, when you are thinking the treatment wise, you should be doing this kind of crossover in the rectus femoris area to get all of these fibers working and moving together. And when looking the next video, we are seeing here the tendon of the psoas. So we are having, when we are taking the tendon of the psoas and picking it a little bit, you can see how it's connected to the joint capsule. So the tendon of the psoas is going here, connected to the joint capsule, and then going towards the spine itself. So in these small connections, they are very intriguing. And also we have to think that where we can have the connections here. And for example, from the adductors, from the anterior part of the pelvis, and also from the area of the gluteus medius, we can have the same areas that are connected to this point. And when looking the Also the connections inside again. Here's the abdominals are taking off and all the intestines are taking off, and you can see how the psoas is coming now. And this area here, I was talking that, okay, here we can have the effect also to the anterior part of the thigh, but also we can have the connections in the more inside to the hip joint area, to the joint capsule area, and also to the pelvic floor area. I could even talk about these ones like the whole day. So this is the thing that 1 hour is way too little for this topic, but let's go. And about the receptors, we are looking the mechanoreceptors. They are sensing tension, pressure, and vibration, and also shearing forces. So everything here we can do with lymphotouch. So we are affecting Pacinian corpuscles, and we are also affecting Ruffini nerve endings. And then we have also thermal receptors and chemical receptors, but nothing more of those in this point. But more we are thinking how we are going towards the Pacinian and Ruffini nerve endings, and also the free nerve endings are important when we are looking the fascia itself, because almost 80% of sensory fibers, they are free, and they can be nociceptive, they can be thermal, and they can be also mechanosensitive. So everything which we are doing with the pressure, compression, and tension, the free nerve endings are reacting. When we are doing very slow techniques, we are connected to the parasympathetic nervous system. When we are moving slowly, we can relax the autonomic nervous system. When we are around the deep fascia in the joint capsule area, in the neck, in the head, when we are moving slowly, we are having this kind of very relaxing effect. And when we are doing this vibrational and this kind of more rapid techniques, adding vibrations and doing lifting and twisting, then we are more affecting the Pacinian and Golgi tendon organs. And then with the stimulation of the receptors, we can have the effect for the central nervous system. Tonus is changing in the skeletal motor units, and then we are having the palpable tissue response. And the same is happening in every receptor. We can stimulate it like in a rapid way, and then we can go with the Ruffini endings and have this kind of local fluid dynamics getting better. We can do the hypothalamic tuning and then change the global muscle tone. Everything is happening there when we are doing tissue manipulation with a finger or with a lymphotouch. And now when talking a little bit about the problems in a fascia, when we are having problems there, this is a new article about Helen Langevin's new article about the fascia mobility, proprioception, and myofascial plane. I really recommend you to read this one. You can find it from this name. And here I took only this one image because it's giving us a good overview. When we are having problems in fascia, we are having decrease in mobility, we are increasing stiffness, and then when we are having problems in the muscle side, we are having atrophy, weakness, and also when the sensory innervation is accompanied, we are having reducing proprioception. And when this pain is activated, we are having active myofascial pain, we are having inflammation, ischemia, and the nociceptors are sensitized. So everything is alerted, and then at this point we need different techniques than what we need when we have this kind of latent myofascial unit dysfunction. We could go more rapid techniques, we could go more deeper techniques, but when we are having more active type of pain, we need to take care of it different way. This is another paper which would be very nice to look, Zugel 2018, because here you can see what things are affecting the fascia and the tissue stiffness. The arrow up will be increasing stiffness, the arrow down will be decreasing stiffness, and if there is this kind of sideways arrow, it is doing both depending of the situation. And I think good example here would be the hyaluronan, which is decreasing stiffness if we are mobilizing ourselves, we are moving, or we are having this kind of mechanical stimuli. But if there is no stimuli at all, then it will increase the stiffness. I could talk about this one also 1 hour, but now we go further because I want to show you the videos also. Couple of words about the fascial dysfunctions, because we can have fibrosis, which is increased amount of fibrotic tissue, and then it's more or less permanent. We can adapt and change things. We can have the tissue more elastic, but it's very slow process. When we are having the adhesion, it's also permanent change in elasticity and structure of the tissue. And these changes can be compensated with other tissues. So when we do things, we can increase the viscoelasticity of the tissues, but we are not getting rid of the fibrosis or the adhesion. But when we are talking about the densification, it's the decreased viscoelastic properties in loose connective tissue, and that we can alter immediately. And there is no histological changes in the dense connective tissue in this place like it is in the fibrosis or in the adhesions. So we can release things in few minutes, but we need this kind of mechanical work on that one when we are releasing things. And now when we are looking scars and thinking what kind of problems we can have there, the damage of the skin, well, that is fairly fast to recover. When we are going deeper and the damage is piercing the superficial fascia, the risk of infection is raising and the time of recovery is of course longer in that place. And when we are going even deeper, we have multiple layers intact, and then the recovery process is lower and the risk of compensation it's raising. And of course we can have a problem where the damage is under the skin and the skin is totally okay. Then the rehabilitation process can start immediately because we don't have to be so careful with the skin and with the skin repairment process. So we are looking next at what we can do. I will give you one example of a scar, and here's horse leg, but this is a good example because here you can see it was an old scar. The horse was caught in a barbed wire, and the scar, it wasn't treated in any way. It was just left like, okay, you have this kind of scar, you can leave it like that. And you can see when the skin is here on the right side, you can see that there is this crater formation. And when we are looking even more close, when I'm pulling a little bit, you can see the adhesional lines. You can see how much adhesions this scar has been creating. And when we are looking the healthy side, it's totally different. It's clear, it's white, you can see the vessels. So in this case, you can really think that, okay, scar, it's very meaningful, and it would be very good to get into that area immediately when we are in the early stage. I will talk about that one also. Here is one acute rupture also from the horse triceps, and healthy side on the left and the rupture side on the right. So you can see how the rupture is there on the muscle. It is collapsing the endomysium and the perimysium of the muscle and creating the problems to the whole body. And now when we are talking that how we could recover from this one, if the one part of the body gets injured, it will affect the whole body. And the phases of the recovery, the first will be inflammatory stage, and then the tensile strengthening of the tissue is very low and it is not ready for the mechanical loading yet. But after that one, after four or 5 days, the fibroplasia phase will start. And at that point, fibroblast and collagen are lining. And it's lining due to tension and compression. And in this point, it's very important for us to work. Of course, we can work in the remodeling phase also, 3 weeks, even to 2 years, but the scar tissue is forming itself, adhesions are there, adhesions are forming, so it would be very nice to work in an acute phase. Of course, when we are having this kind of inflammatory phase, when it's happening, all the vascular neural system, everything is facing the rapid and forceful stress, and at the acute phase, we could limit bleeding by cold compression elevation. And now there is this kind of new protocol of peace and love. So protection, elevation, avoid anti-inflammatories, compression, education. And then after that one, you could load, have an optimistic mind, and then exercise and do this kind of movement to get the vascularization back. But at this point also, you could use lymphatouch. We could use negative pressure, and we could reduce swelling, pain, tenderness, and relax the tissue around the injured area. If you are working in this kind of acute phase, you could do the treatment daily or 2 to 3 times per week. You could estimate swelling, and treatment is very possible to start in early, almost after the injury immediately. And we are activating the lymph nodes. If you have, for example, this kind of ankle sprain, you could activate the lymph nodes in the thigh area with the holding techniques and pulsation. And then you could glide along the muscle belly, but not go directly in the acute area if it's having this kind of inflammation stage. So remember that 3 or 4 days, you can avoid the area where the biggest swelling is. You can be around and have a good improvement with that one. And then when we are going to the proliferation phase, with the active movement, we can do isometric contraction, we can use active stretching, and then do dynamic exercises, pain-free range of motion. Those would be the things we could recommend from the movement-wise. But when doing what we could do with the lymphatouch, we could be in a myofascial change. Notice swelling, so you could use light negative pressure, and then you can get nearer to the scar and follow the myofascial lines with the gliding techniques. And with these ones, again, slow gliding, because we want to also get the autonomic nervous system relaxed. So in that way, again, slow gliding movements. And then when we are going to the third phase, we could be on top of the scar. That is very individual how the people can take it. And we are increasing the negative pressure. We can use the lift and twist techniques and also the crisscross techniques. And now when we are there after 3 weeks, even to the 12 months, we are in the remodeling phase. We are using dynamic exercises, functional training, we are getting back to the sports. And in that phase, we are following again myofascial lines with the gliding, and now listening carefully how the feelings of the patients are, but we can be now in the scar area. We are doing the elasticity of the scar area and lift and twist techniques, and we can even use the sport settings to get the crisscross techniques going on and support the overall elasticity. When the people are getting back to the work, they can be having good support from the treatment itself. Here is one example where I have been using lymphatouch and also taping, and here we did the myofascial lines at the first one. This one is the joint replacement for the hip, a 60-year-old woman, and the treatment was done post-operative 2 weeks. This is from that, and here you can see the same lady with the same leg, 5 weeks post-operative, and we did 2 treatments between this one. I was using lymphatouch and I was using also taping techniques to get the swelling off. Okay, time flies, but I'm showing you the videos next. So here we are having abdominal scar. The scar itself, it's 40 years old. The lady is in her 50s, and she was child. She was 8-year-old when they removed the kidney from her. And this scar has been treated with lymphatics previously. So you can notice from this one that how the elasticity is in different directions. So it's still a little bit, quite often, her scar, it's having this kind of adhesions on the left corner, but still you can see from here when I'm touching it, how flexible it is in different kind of angles. Here in this point, you can see how the tension is going to the lower abdominals, and you can see in the next video the treatment for that one. So we can vary the length of the pulsation. If you're having older scars, use the firmer pressure. You could use the vibration to get the effect deeper. And remember what I was saying about the mechanoreceptors. When we want to activate the Pacinian corpuscles and the free nerve endings, use the vibrations. Use rotations, use twisting, and also gliding along the scar. We are using twisting and lifting techniques. And also, of course, you can hold in place if you feel the adhesion, and then add rotations there. And here I'm first using the vibrations with that one. So you can see how it is lifted, and then I'm doing only holding and using the 90 Hertz vibrations at the same time when I'm doing this one. And then when I'm doing it, I'm always feeling the tissue at the same time. I'm feeling it first with my fingers, and then I'm thinking that, okay, when I'm going through the lymphatics, that how it is going. That was the corner where we had the biggest adhesion. So there we can increase the pressure and use also holding techniques and rotational techniques and twist it. And now it's good to remember that when we are treating scars, we need to be very individual, because there is no similar scars, although there would be same kind of operation. The adhesions and the compensations are always individual. So rotations, criss and cross techniques. And after the treatment, when you are palpating the tissue, you should feel that it is way more relaxed. The movement between the layers, it's better. And the area of the adhesions, it's more elastic. Although we don't get rid of every adhesions, we can have elasticity for sure. And here in this video, you can see the facial scar. So it is under the under here, the lady was falling out of some kind of rocker when she was small, and this was first time she got treatment for this area. And sometimes even the small scars can cause tension and lead to compensation. So remember to check if the client is saying that, okay, there is head problems. There might be old scars, for example, in the chin area, in the forehead, in the eyebrow area. So it might be that when was a child, there might be that there has been some falling of somewhere, and then there might be problems after that one. She was complaining also a little bit tension under the shin, and also sometimes problems in the temporomandibular joint area. And the area of this scar, although it is fairly nice, you don't see it so much when you look it like this. So it is not so visible, but still it was very tight. So it doesn't always mean that when you are seeing the scar, you have to also feel it. It's not only that looking by a scar, you could say that, okay, this one is fine or it is not fine. And here I'm using a little bigger nozzle to have more suction on there. And this one, the patient was saying that it doesn't feel painful, it feels only tight. So in this way we could use a little bit more pressure on this one. Okay, and then the next one will be the shin scar, and we are now on the lateral myofascial line. So again, holding, lifting, and with and without pulsation, slow gliding, twisting, and then continuation to do the whole lateral line. And you can also vary the pulse length here. And like I was showing you from the dissection image, the head of the fibula here, there is tension in an anatomical way also. And now when there is also a scar in that area, she was saying that, okay, there's a lot of tension in this area, which is bothering her a lot. And this has been, the lady is rider, and she has been saying that this is really bothering her when she is riding, because this is creating this kind of deep pain, like there in the head of the fibula. So we were going directly to the area of the scar, and this one is also a scar that hasn't been treated so much with the lymphatouch. So it is the first time she is having this treatment for this scar. So we are going along the scar itself, and then changing first. This may be the best way to go first, gliding along the scar. And then you could start to add the rotations to feel where the adhesions or where the tension or where the densification is. And then you could add this kind of small rocking to the suction. So get the idea that, okay, the pressure is there. And of course you have to ask from the patients at the same time that is there pain, because you should also reduce the pressure if there is too much pain when you are doing this one. With this one, after I take the nozzle off, you can really see how much vascularization there is. And also with the gliding techniques, now I'm doing the constant pressure, so we are not taking the pulsations at all in that one, because the area was very tight, but the patient was still saying that it is not painful when I'm doing it. So it is like very heavy pressure now, but the scar is old, and you can see how much it's doing the suction here when I'm taking it off. And here you can see how we are following the line. So we are going the lateral line to the area of the vastus lateralis, and having also the we can have a little bit lifting there. You can see I'm lifting a little bit. And then we could also add here, when lifting, we can do also crisscross techniques and do the rotation on both sides. And always remember to do, when you are doing the rotation, do it both sides, so you could get the gliding of the fascial layers in many ways, so you don't only do one layer. And here I added a little bit fast pulsation to get the receptors working, the free nerve endings, the Pacini and corpuscles working, and then I'm moving also more faster. So get it, the faster movement, getting more activation there. Okay, as a conclusion, different structures are healing in different speed. And think how big is the injury, how deep, how largely it is affecting. Give enough time for the body to heal itself, because collagen turnover time is about 1 year. And remember that hyaluron turnover time is 3 days. So movement, controlled movement, treatment to support the body to heal itself, and appropriate loading is also very important. And we can start right after the acute phase, and we can go with the therapeutic modalities according to the patients and the resources she or he has. Okay, I'm more or less done. Oops, let's take
Thank you
here.
so much.
Yeah, no, it's like yep, good. There is a lot of questions I can see.
Yeah,
So
there are
we
many
can
questions. I can ask them and you can be the one who replies them.
Yeah.
We are running a little bit over time, so
Yes,
I just
sorry
wanted,
about that one.
no, don't worry about it. So just to let everyone know that we are recording this webinar and it will be available afterwards. So we will send you the link to this webinar in any case. But if you have some extra time and if Tuulia has some extra time, we could take few of these questions. So first of all,
yeah,
thank you so much
yeah.
for this very interesting presentation and amazing demonstrations as well. It's very interesting to learn from one of the pioneers in this exciting field of fascia.
Yeah.
But one of the questions was that clinically, how do you differentiate between densification and adhesions or fibrosis?
Yes, that's a good good one. And the thing and the answer will be that if you get rid of the problem, when you feel the elasticity between the layers, it was densification. But if you still feel the strings and you feel that there is still something holding on, that's a fibrosis, like roughly said, that the densifications you get rid of in a couple of minutes. But if you have a fibrosis or adhesions that will be there, it will be holding something, you can have improvement and you can have viscosity, more elasticity on the tissue, but still you feel that there is something. Okay, the next
Perfect.
one.
Yes, perfect. Thank you. Then there was one question about using the LymphaTouch. I think I lost the question. Okay, now I'll find it. So when applying the LymphaTouch, do you also use a light lubricant or dry? That was one of the questions.
Yeah, lubricant would be a good one. You could use the ultrasound gel. You could use any other gel you have. You need something to have light lubricant if you want to do the gliding techniques. So that would be very good to do with those ones.
Yes, exactly. And then one more question. I would like to know the startup pressure to treat scar tissue and how long the session should take. And also, is it necessary to activate the lymphatic pathway and nodes near to that scar before the scar treatment?
Yeah, that would be very good. There wasn't any video example of that one there, but that's a good way to go. So you first activate the lymph nodes. For example, if you have ankle sprain, you go in the area of the thigh, you activate the lymph nodes, and then you come along the myofascial lines. What was the other part of the question?
And there is also that how long is one treatment?
How long? Yeah, that would, yeah. So it takes what it takes. So it's very individual. So it's a little bit hard to say. Quite often you can have a lot of improvements in few minutes, but sometimes it takes really time to get rid of. If you have, for example, a C-section, which is 30 years old, so you have a long period time, or like the scar has been there a long time. The body has been creating a lot of compensations, and then you are starting to treat it. It might take quite a while to get rid of the problem. But sometimes, for example, the scope scars, for example, you just take a couple of minutes and they are okay. So it depends of the depth on the area of the, and also the ability of the body to heal itself. If you are eating well, you are lubricating yourself well, you are giving all the nutritions that the body needs to heal itself, it needs only a little bit help outside. But if you are eating bad and you are the tissues are too dry, and then you are going that you might have a lot of problems also in treatment.
Exactly, and there was also the question about the pressure, amount of pressure when you start, but that's also
okay,
very individual.
That's very individual. So it's better to go first with a light pressure. And if the patient is saying that, okay, I don't feel so much yet, then you increase a little bit. And if the patient is saying that, okay, now I feel it's getting maybe a little bit pain, then you come a little bit back from there and start from that one. So pain is always the thing that you should respect. And of course, if you feel that the whole body is tensioning when you are doing it, you are having too much pressure on that one. But of course, it is not wise to do too little also. So if the patient is not feeling anything, then you have to add it. So it's really individual for sure.
Exactly. So the follow-up of the patient is always very important, and also the communication with the patient. So
always ask and also look, because sometimes, for example, in Finnish, people like Finnish men, they are all, oh, I gotta handle it. And if the body is so tight, you can't get the lubrication for that one. So then it's better to just reduce the pressure, because of course, quite often they can be that, okay, you can put maximum, you put your sport there and maximum power for me. And that is maybe not always the good thing.
Exactly. And then there is one more question. And if anyone has any other questions or anything, you can always send us email and we can come back with the answers. But one more question is that, can you say something in general about lymphedema and scars and fascia? Something in
general. Okay. With the lymphedema, I would go first with the pulsation, gliding techniques, and slow gliding techniques, because quite often there is at the same time the sympathetic nervous system is way too active. So you need, at the same time, when you need to get the liquid going on in the body, you also need to get the relaxation for the body. So that would be maybe something general that, for example, after breast cancer, when you have also the feelings and the emotions are connected at the same time there. So you are having, the people are afraid, they are maybe thinking, are they surviving from this one? Then they are having scars, and then it's the lymphedema is coming also together. So you are having this kind of complex case where you have feelings, emotions, and almost every scar, there is component of something emotional there. For example, cesarean section, you get your baby from there, but still at the same time you feel pain. So it's like it can be very controversial. And of course, if you are having, for example, breast cancer, and you are afraid and you don't know what to do, you may lost your job, and then you are at the same time suffering problems in your body, that would be very tricky to heal, because it might be, well, not the easy case. Let's say that in general.
Exactly. So that was all the questions today. If we missed any, we will come back with the answers again. And if you are interested in hearing more about LymphaTouch or the treatments and how to use in different indications, you can always contact us at contact@lymphatouch.com. One more time, Tuulia, thank you so much for presenting today. It was very interesting for all, and we already received so many comments in the chat that your presentation was super interesting.
Yes, thanks. Excellent.
Thank you.
Good. Thank you. Bye.
Bye.